So anterior fibular dysfunction, as if that the fibular head is sitting anteriorly. So your job is that you're putting your hand on the fibular head to move it posteriorly. So that would be your truss technique. So there are ways to get into it, which is make it easier. One is that, hold on to this. If I turn the foot in, internal rotation of the leg, the fibular head comes in my hand, nicely aligned. So I would be able to do my truss technique. Same way, I'll find the fibular head, I'll turn the leg medially, or internal rotation of the leg. So the fibular head, it comes under my hand. And I personally, I could do easier if I cross my arm. And that would be my truss technique is gonna be. So if you notice that I'm turning it in, a fibular head comes in my hand, and then I could do my simple truss technique. Go ahead.
But this one doesn't have dysfunction.
No. So the fact is, when you are turning the leg in, you're actually aligning the fibular head for mobilization or truss technique, and that's how it's been placed. So, I mean, as I show it to you, I could do, without crossing my arm as well. I mean, there is no limitation in that regard. But rather than, I'll find it easier for myself if I cross my arm. So that would be addressing anterior fibular head dysfunction. Now the posterior fibular head. So remember, I did internal rotations for anterior. Now I gotta do external rotation for posterior. So posterior fibular head dysfunction is that if this is sitting on posteriorly, I want to move the fibular head anteriorly. If I put my MCP contact on the fibular head and external rotate the leg, that is further pushing the fibular head to my MCP contact. Simply, if I get to the limit of the barrier and I have my hand fixed on this, I could simply do my truss technique. And that is moving the fibular head anteriorly. Like that.
So basically you're using a lever
Right.
to stabilize the fibular head posteriorly with your MCP joint, and then you thrust the shaft of the fibula, and that moves the head anteriorly.
So if you notice that, I put my MCP contact on the fibular head. I external rotated it further, coming on towards my hand. I would probably put my hand this way because I'm going to be better control. This is external rotated. I'll bring it up to limit of barrier. My MCP is in contact with the fibular head. I simply do my truss technique. This is stay put, and the other one is basically doing the movement. As I say that often, that if I could just tuck the leg and close to my trunk, because then the amplitude of the truss is a better controlled. So you have the short amplitude, but rather than a high velocity. So if I want to show it on the other leg, you could see that the MCP contact, I'm further away from the patient. That's not the desired mobilization or thrust. External rotation, bring it up further, and just simply as I go, so you do your thrust technique. This is just only for demo of you guys to sit, but rather than this is the better technique because you're close to the patient's limb is close to you, and you simply do the external rotation, MCP contact, fibular head, you do your thrust technique. So the last one in this group